Today I would like to demonstrate how I perform an arthroscopic Bankart repair and arthroscopic remplissage. This will concentrate on the remplissage part of the procedure. Today we have a 30-year-old male who is right-handed and sustained a traumatic anterior dislocation. He has recurrent instability, no signs of generalized hyperlaxity. The MRI scan shows an obvious Hill-Sachs lesion and an anterior Bankart lesion. In this particular case, the Bankart lesion has a small bony component, as demonstrated antero-inferiorly in these sequences. Viewing through an antero-superolateral portal, we can see the antero-inferior Bankart lesion. We are also able to see the Hill-Sachs lesion demonstrated here on the posterior humeral head. A posterior percutaneous metal port is established. This has been found to be very useful at roughening up the humeral head to bleeding bone, as demonstrated. A pilot hole is then drilled posteriorly and a 2.9 mm biocomposite suture tack is then inserted. In this particular case, the superior one was placed first. The percutaneous port is then withdrawn and a second port is established percutaneously. A second pilot hole is then established through the inferior percutaneous port. Once this has been completed, a further 2.9 mm biocomposite suture tack is inserted, and this time the blue suture is removed, leaving behind a blue suture superiorly and a white suture inferiorly, which will be tied once the Bankart lesion has been repaired. We now turn our attention to the repair of the Bankart lesion, viewing through the antero-superolateral portal. The Bankart lesion is repaired sequentially from inferior to antero-superior. In this case, 4 anchors were used. Once the Bankart lesion has been completed, the scope is placed in the subacromial space and the remplissage sutures are identified and located. Here you can see them becoming visible. A clear twist-in 7 mm crystal cannula is then used. The portal is established and the white suture and the blue suture are retrieved. They are then secured, creating a mattress suture, which essentially creates the remplissage effect of filling the Hill-Sachs lesion with posterior capsule, as demonstrated here. Post-operative care involves elbow and hand exercises for 10 days, followed by passive and active assisted movements from 2 to 6 weeks. He will wear a sling for 6 weeks and avoid external rotation past 10 degrees for a full 6 weeks. When the indications are correct, this has been found to be a very successful procedure. Thank you for your attention.